I'm one of the advanced critical care practitioners from NHS Lothian, and I'm just going to try and give you a little bit of a flavour as to how we've went around setting up the service over the past couple of years, and actually what we do as part of our job and our role on a day-to-day basis. I'll start off just by giving you a little bit of a history, because the role of advanced practice and intensive care took a slightly different path to other advanced nursing practice roles. They did have a common start with the publication of the New Ways of Working in 2000, which really aimed at educating and training people to take on some of the roles that were traditionally done by more of the conventionally trained professionals. And these included the introduction of quite a number of advanced roles, from physicians, assistants and anaesthetics to the emergency, acute and surgical care and neonatal practitioners. And most of these had a nursing background with extensive experience. And one of the exceptions to this is the physician's assistants, who were science graduates that had no healthcare experience, and I'll touch on this a bit again later. One of the other things with the advanced critical care practitioners is that it isn't only nurses that do the job. There is one person that I'm aware of that's from a physiotherapy background that does the job down in England. The critical care practitioners weren't really involved in the initial wave of development of advanced practice, and it really wasn't until 2004 that the New Ways of Working in Critical Care group seen the other roles being developed, and they thought that really it would be something that could be quite advantageous to the service that they were trying to deliver. And on the back of that, the Department of Health commissioned 6 trusts in England to really explore the role of the critical care practitioner. And at this time, they were also funded to look at another subgroup, which was assistant practitioners. And this was an initiative to train predominantly Band 3 healthcare assistants to do some of the less specialised tasks that had traditionally been done by the Band 5 nurses. And as far as I'm aware, that's a role that really hasn't been developed much anywhere in the UK. So after this pilot scheme was completed, the Department of Health published a national framework for advanced practice and critical care, and they published it in association with the British Association of Critical Care Nurses, the Royal College of Nurses, the Intercollegiate Board of Intensive Care Medicine and the Intensive Care Society. And what they set out to do was to provide a framework for the competency and education, and give a bit of an outline as to the role as well. And I think this publication and the intention to introduce it as a national standard really is one of the main differences between this and the other ANP roles. Obviously, the underlying driving factors were still the same, and the requirement to try and get the medical staff to comply with the European Working Time Directives, and also the changes to the medical career pathways played quite a big role in that. From a more local perspective, in 2008 the Critical Care Directorate at NHS Lothian put forward a business case to the Basel Group, which is the Better Acute Care in Lothian. They were a group that were set up at the time, and their remit really was to look at new and new ways of bringing forward the service delivery. After about a year of deliberation, they accepted the business case, and they've provided funding for 14 critical care practitioners in NHS Lothian. Not long afterwards, in fear of losing that funding, the first cohort of training commenced. There was 14 spaces, like I say. I'll talk a little bit about the interview selection, but only 13 candidates were successful in the application, and there were 7 in the first cohort, and then 6 in the second cohort that followed training 6 months later, just to try and reduce the workload and training of it. So it all really started with the interview process for us, and this was quite an arduous process. It was split over 2 days. The first day was really based around an OSCE scenario that had 3 main stations and followed a patient journey. The first station included leading a team in an ALS scenario that was specific to critical care. I think it was a tension pneumothorax on a patient that was getting ventilated. Then the second scenario was an interpretation of results, including chest x-rays, blood gases, ECGs, and other blood results, and we had to discuss our rationale for formulating a diagnosis. And this was really aimed at trying to assess where our clinical decision making and critical thinking were at. Then into the third station, we had to hand over to a specialist medical team and also inform the relatives of some bad news, again with the aim of assessing the communication skills. We then had to come along, thankfully on a separate day, to undertake a formal panel interview which consisted of a consultant in intensive care, a senior nurse manager, and the appointed lead for advanced critical care practice. And like I say, not all the positions were filled. There was a total of 13 candidates that were successful, and they proceeded in two separate groups. So as part of the education pathway, it was a collaborative module, a collaborative project along the MAC Advanced Pathway, and that was between Napier University in Edinburgh and NHS Lothian, and that's a model that's now been adopted by other trusts in Scotland that are looking at bringing this service in. The first module that we done was clinical assessment and history taken, and this included a kind of blend of learning styles. It included lectures to bring us up to speed with anatomy and physiology, mentorship, and competencies that were overseen mainly by acute medicine registrars. And it also had some academic assignments that were aimed again at assessing and improving clinical decision making and the application of the evidence base that would be useful to us. Most of this module that we done took place in the acute medical wards, just really to give us more exposure to the clinical signs that we were looking to familiarise ourselves with. Following that, we went on to the second module, and the second module was a work-based learning module that kind of really built on the foundations that we had learned in the first module, and the difference being that this was done within our own clinical area within critical care. And this module included learning some of the practical procedures that were required of us, again critiquing the literature and the application of the evidence base, and also included appraisals that were used as assessments with the Faculty of Intensive Care Medicine and the medical pathways. And that was the DOPS, which is a direct observation of procedural skills, where you'd be observed doing certain procedures. The mini-KEX examinations, which involved, again, being observed, assessing critically and acutely ill patients, and case-based discussions that you would sit down with one of the senior medical staff and just discuss one of the patients that you had been through and all the implications of the care that they required. This culminated in handing in a portfolio that was really a way of trying to express the learning that we had done over this module. The third, and again quite a difficult aspect of the training course, was the non-medical prescribing, because really this was a module that had been designed for use predominantly with the community practitioners and didn't really cover all the educational requirements that we had at the time with respect to the implications of prescribing to the critically ill patients. In order to go over that, our clinical education team ran a number of parallel study days covering the topics that we needed really to ensure that we were able to prescribe safely in our patient group. And this really covered topics such as pharmacology and the specialist drugs that we would be using, as well as achieving the NMC competencies and the academic requirements of the course. So these three modules constituted the mandatory element of the education. We have been funded to go on to complete the master's programme, and the first cohort are currently undertaking their research and dissertation, which, believe it or not being a mandatory part of the job, we must be crazy to go ahead with, because it is quite another big workload that we've taken on almost voluntarily. The last section here is a bit more of an ongoing educational feature of the job, and that's continuing professional development. We've got the luxury of being allocated one session a month for this, and it really is geared at allowing us to maintain our skill set and develop it a bit further as well. It's directed by ourselves. We organise topics that are of interest to us, and for any teaching that we feel we need. And we are also have an individual consultant mentor that we meet on a 6-monthly basis, just to ensure that the individual needs are being met as well. So what is it that we actually do? Well, it's quite a question that we've come across quite a lot, especially as it's quite a new role. We do work predominantly with the medical teams, but that's not to say that we've turned our back on nursing. We're all still nurses at the end of the day. But what we do is we try and help the integration between bed-based nurses and the medical staff, and contribute to the decision makings that are required to deliver a more effective service. We also carry a bit of a responsibility for an education role, not just with the nurses staff, but with the junior doctors that rotate through the unit and with the other members of the multidisciplinary team. So a big part of our role is the recognition and assessment and the management of the critically ill patient. This is done through a variety of means. It's done by reviewing the patients on a daily basis, as and when the need arises with a deteriorating patient. In some cases, referrals to critical care on the medical emergency team, as well as quite a recent development. We're also involved in the diagnosis of elements of critical care illness and ensuring that the management of the illness that they have is appropriate and safe. We also prescribe a number of things. We prescribe interventions that are used for organ support, such as ventilation and hemofiltration, and also pharmaceutical interventions. It's quite a new area, as it probably is with a lot of you, the non-medical prescribing in the role of advanced practice. So we really had to design a framework, which is highlighted in one of the posters over there, again to facilitate the safe introduction of non-medical prescribing to our area. And we've done this by developing a core formula of drugs that we felt that we needed to be competent in prescribing, and then we developed this further on an individual need with input from our mentors. On the background of a couple of successful pilot programmes undertaken in Lanarkshire, we're now also able to authorise blood and blood products. We're responsible for ordering diagnostic tests on our patients to help confirm or refute diagnosis, such as chest x-rays, ultrasound scans, and in agreement with the consultants we will order CT scans and are fully compliant with the IMR regulations that we need to in order to do that. We do undertake some procedural skills, such as arterial line insertion, difficult peripheral access, assistance with rapid sequence intubation, and assistance with bronchoscopy. There is another important element to our role that Kelvin had mentioned earlier, and that is the auditing part of it. We are involved in continually auditing and benchmarking and trying to improve our clinical practice.